Hi, everybody, and welcome to week 1 of the ARC Michigan's Disability Policy webinar series. I have a few housekeeping items before we get started. So if you are not familiar with GoToWebinar, you're going to want to look for that orange arrow in the upper right-hand corner of your screen. This toggles your GoToWebinar control panel. If you're joining us via your phone, the control panel is in a pull-down menu at the top or bottom of your screen. If you have any issues with your audio, you're going to want to go into that control panel and do a sound check for your mic and speakers. Participants are muted for this presentation, but questions can be typed into the GoToWebinar question window within the control panel. A link to the handouts will be shared in the chat area and are available at www.arcmi.org. If you lose your GoToWebinar screen, look for that blue flower icon in your taskbar to bring it back up. Now I'll hand things over to Sherry Boyd, CEO and Executive Director of the ARC Michigan. Good morning, Sherry.
Good morning, Emily. Thank you. I want to thank everyone for joining us this morning in our first of 4 series for our Disability Public Policy Seminar. Today we have folks from the BPHASA, which is the new name for Behavioral Health and Developmental Disabilities Administration. We have Belinda Hawk. She's the Director of the Adult Home and Community-Based Services Division within MDHHS, which oversees services and supports primarily funded services by Medicaid, mental health, and the SUD block grant dollars in the Michigan Behavioral Health System. Previously, Belinda served as the manager of the Behavioral Health Federal Compliance section within the former BUDA, and she has over 30 years of experience working in the field and as a provider. After Belinda, we have Remi Romanowski Pfeiffer from TBD Solutions. Remi guides communities and organizations in quality improvement activities related to planning, service delivery, and organizational strategy. She helps organizations leverage their assets, including their perspectives of those they serve, the skills of the employees, and relationships with partners in their communities. And lastly, we'll have Alan Jansen speak, and he is the Senior Advisor to Director Elizabeth Hertel, and his primary focus is on behavioral health. Previously, Alan served as the Behavioral Health and Developmental Disabilities Administration Director. He's been working in the mental health system for over 4 decades, and we look forward to hearing what he has to talk about this morning. So without further ado, I'm going to turn it over to Belinda, and thank you, Belinda, for being here this morning.
Thanks, Sherry, and thanks everyone for inviting us again this year to participate in your webinar series. Today we're going to cover a few topics that we would have covered last year and provide updates in those areas, as well as bringing in some new topics that are relevant to your interest in your audience. So the way that we're going to handle this, since we do have 3 presenters, is I'm going to go through my topics. I'm going to pause at the end of my presentation to offer you an opportunity to ask questions through the question chat box. And then Remi will take over and present on conflict-free access and planning. And then Al Jansen will come in and present on the direct care workforce topic at the end. So every time a new presenter, before a new presenter starts, we'll again offer you an opportunity to ask questions before going into the next set of presentation slides. So let's go ahead and get started. Next slide, please. So again, the overview of the topics we're going to cover today among the 3 presenters will be those that cover our waiver and state plan amendment public health emergency unwind plan, as we are anticipating the public health emergency coming to an end at some point soon. We're also going to cover the any updates to the 1915I state plan, the Hcbs rule implementation status and where we are as a department in implementing that rule. We're going to then move to conflict-free access and planning, which you may be more familiar with the title conflict-free case management. And Remi will talk about where the department is in moving that work forward. And then again, the last topic will be where Al Jansen is able to give the audience an update on the direct care workforce efforts by the department. Next slide, please. So this again might look familiar because this was a slide presented last year where we just provided you with an overview of what we were able to leverage in federal flexibilities related to the public health emergency in our waiver authorities. So I just wanted to highlight that the one that we, I know is of interest to many is the telehealth, telephonic expansion flexibility and whether we're going to be able to continue to leverage that flexibility going forward. But again, this is a reminder of what flexibilities currently continue as we are still under a public health emergency. And those are basically areas of allowing pre-existing authorizations to continue, again, temporarily or provisionally enroll or reimburse new or out-of-state providers who might be able to provide telehealth services. If there is a need to provide services in an alternative setting, that is a provision that we are able to leverage. Telehealth and telephonic expansion, again, and then the flexibility to allow the person-centered planning process to be flexible in how it's extended during a public health emergency. Next slide, please. This is another authority, which is the 1115 Managed Care Authority for Behavioral Health. And under that authority, we were able to leverage, again, some flexibilities related to the public health emergency. And you'll see that they can overlap in what we request in the way of flexibilities. But because these are different authorities, we do have to ask for those flexibilities in each authority. So person-centered planning, expansion of telehealth, allowing the annual reassessment requirements to be beyond the 12-month period if needed. Evaluations and reevaluations could be modified as far as the criteria for requiring those payment for services and supports to providers. There's flexibility in how that is offered through alternative settings that may or may not be home and community based. Looking at making sure that we have payments to certain care providers to maintain capacity. So that's really kind of reflection of the direct care wage increases that you may be aware of. And then any requirements related to data sets or data requirements as far as time and or scope may be unavailable during a public health emergency, so those were allowed to be modified as well. Next slide, please. The last authority that we in behavioral health had to make sure to leverage was the Appendix K flexibility, which would impact our 1915C waivers, which serve people on the Have Supports waiver, the Children's waiver, or the SED waiver. And again, it looked at allowing for certain service limitations to be exceeded, like private duty nursing, for example, expand where services could be provided, again, to address the need for people to potentially get services in a non-HCBS setting, modified requirements around provider qualifications, level of care evaluation and reevaluation requirements were also able to be modified or extended. The person-centered planning process, again, had some flexibilities within it. Excuse me, just for a minute. Sorry, I'm recovering from COVID, so I'm hoping my voice holds out. Increased payments to providers, and again, allowing for payment of services to support people while they're in acute care hospitals or short-term institutional settings for the purposes of maintaining their supports and services while in those settings temporarily. Next slide, please. Doesn't look like we're advancing the slides at this point. Is there maybe an issue? Oh, okay, good deal. We're back on track. So related to the public health emergency, we expected that the public health emergency might be coming to an end in July of this year, given that the last approval received for the renewal of the public health emergency was April the 16th. We, though, have now been assuming that because the state had not been given 60-day notice prior to the public health emergency ending, that it would not be renewed, that it will now be renewed for an additional 90 days. So we do have an expectation that although the 90-day public health emergency timeframe right now is set to end in July, around the 15th of July, we do expect a renewal of the public health emergency beyond that date for a 90-day period of time. Next slide, please. Looks like there's a bit of a delay in getting our slides moved. So I'll go ahead and continue to talk and hope that folks can follow along. So just to remind people, as I kind of covered the different authorities that we've leveraged during this public health emergency, what exactly happens at the end of the public health emergency for each one of those authorities. So if you see that the 1135 authority was effective March the 10th of 2020, but at the end of the public health emergency, the authority for those flexibilities will also expire. So there isn't a window of time after that public health emergency for any of the flexibilities that would have been allowed under the 1135. For the Appendix K, or the 1915 C waivers, again, we had the effective date March 10th, but we do have a 6-month period after the public health emergency to allow for those flexibilities to continue as we transition back to normal operations. And then under the 1115, or the managed care component of our authority, it took effect March the 1st of 2020, and there's an expiration of those flexibilities 60 days after the end of the public health emergency. So just again, want to remind everyone that we are working as if we are anticipating the end of the public health emergency coming sooner than later, and looking at each one of our flexibilities to assess whether we want to continue to leverage those flexibilities, and if so, how to do that. Next slide, please. So the ways that we can are looking at the flexibilities and the public health unwind, the emergency unwind, is to really take a look at what are our flexibilities now, what each one of those authorities allows in the way of a window of transition time, and then consider whether we want to look at continuing those flexibilities. And how we do that is we either leverage the allotted time that each authority may have for those flexibilities after the public health emergency ends, and temporarily continue those flexibilities, or we amend those different state plan and waiver authorities, and in that amendment, make those flexibilities permanent so that we don't need to continue to request those flexibilities temporarily, but to actually include them and incorporate them in a permanent flexibility within the authority of that benefit. Next slide, please. So I wanted to make sure you were able to go to a website that is on the slide here that speaks to all of the efforts of the department in the public health emergency space. So if you go to that link, it will point you to resources that are unique to your particular interests, as well as frequently asked questions. There's also, I know, a series of webinars that have been offered by the department related to the PHE, or Public Health Emergency Unwind. There is one, I think, remaining in that set of trainings, and that I think is offered next Tuesday the 7th. It's the last of 3. If you see that when you go there and it appears as if those trainings are already booked and sold out, that you can still attempt to register, because they have expanded the ability to take on new attendees, and they're making those decisions as they see an interest growing in people wanting that information. Of course, those webinars will also be recorded and will be available on this web page for future review if you aren't able to make that those particular dates. Next slide, please. So we're just going to move to just a quick update on the 1959 state plan. Again, we covered this last year, where the department had pursued through an 1115 the 1959 state plan benefit, and we are again in the process of asking for an extension of the go live or implementation date of the 1959 from the October 1st of 2022 date to another year out, asking for an October 1st, 2023 date. And one thing we wanted to make sure that we covered in the next slide, so we can go to the next slide, is just what is covered under that state plan 1959. So these are behavioral health services that you would have traditionally or historically known as the B3 services, where we move the authority for those services out of a B authority into a 1915I. And those are listed here. So community living supports, family support and training, FI services for self-directed arrangements, enhanced pharmacy, environmental modification, housing assistance, skill building, specialized medical equipment and supplies, supported or integrated employment, respite, and vehicle modifications. So those are the benefits that are going to be under the 1915I and are actually in play now since 2019. But in the next phase of implementation, there will be a requirement that the department review eligibility for this benefit before the services can be rendered. And that's what we're asking for, a year delay in implementing so that we can have the proper infrastructure in place for that, that work to be done. Next slide, please. So we're going to move to the Hcbs implementation, or the Home and Community-Based Services Rule implementation. Again, remembering that the Hcbs rule is a federal rule that took effect in 2014. However, there is a component to that rule that is allowing states a transitional period to get their provider network in compliance with the rule. And the rule, of course, is expecting that all providers will be in compliance with this federal rule by March 17th of 2023. So at this point, the department is looking at those providers who, by way of a survey and subsequent site reviews by the department, were determined to be on heightened scrutiny. And those providers now are out for public comment, or the settings are out for public comment for 30 days. And that we've made the decision to break it into 2 phases of public comment. So the first phase is Region 5, and that ended on 5/12 of this year. And the remaining regions of the state with their provider network will start at the end of actually the beginning of June. So what we have to do at the point that the public comment period is over is to look at the evidence provided. And if the setting is to be determined to be home and community based by way of the public comment and all of the evidence that we would have obtained through our site review process, we will make the determination to send those settings to CMS for final review and approval. So it is the final approval is by CMS, or Centers for Medicare and Medicaid Services, with a recommendation from the department. For those settings that were determined not to be home and community based by all of the evidence reviewed, those settings will need to be notified that they were determined not to be home and community based, and the individuals that are living or getting those services in those settings will need to transition from those settings by that March 17th, 2023 timeframe, or will be ineligible for Hcbs Medicaid funding. We will then move to the next phase of assuring that we have ongoing monitoring and verification that those settings remain in compliance with the rule in and after 3/17 of 23. Next slide, please. So the last slide really is just sort of an explanation of where we have the survey process and the public comment process and the review by CMS put together in just a more visual format. So again, it is just a visual representation of what I just covered. So again, it's just an overview of that heightened scrutiny process and where the department is in each step of that process. So at this point, I'm going to go ahead and hand it off to Remi, who's going to give us an update on the conflict-free access and planning work group. But before I do that, I just want to check in to see if there are any questions that have come in through the chat. Hearing none at this point, I think we can move on to Remi. Remi, are you ready?
Yes, I am.
So I'm not seeing our slides advancing, Remi, so I'm hoping that, yeah, we can have folks, we can talk through those slides if folks can't see them. There we go. It looks like they're caught up now. Thank you.
Yeah, thank you so much. We can move on even to the next slide here, just to jump right into context. And then from there, we'll give an update on the work group process and where the work group is at. So you can go ahead and proceed to the next slide. So we want to start with what is conflict. So conflict is when, as defined by CMS, is when a single provider organization does eligibility needs assessment and provides those direct services and supports to a person. And then go ahead and proceed. Another area that is a potential conflict is when a single provider facilitates that planning activity and also provides the direct service and support to the person. So this was previously referred to as conflict-free case management, as Belinda mentioned, and as you might remember from last year's presentation at this webinar. But you can see here that referring to conflict-free case management isn't as specific as referring to conflict-free access and planning. So you can see that eligibility needs assessment as access, and then planning, there's those planning activities. So you can go ahead and proceed to the next slide. So here we just wanted to show you where that name change came from and show you those two specific scenarios and why it transitioned from case management to the title access and planning. So in general, CMS defines conflict as when a provider organization can conduct eligibility needs assessment, planning activities, and provide that direct service or support to the individual. Go ahead, next slide. So this slide sort of walks through or outlines what the potential conflict is. So when a single provider conducts those eligibility needs assessment and provides the direct service or support to the person, there may be an incentive to determine someone eligible or ineligible. And then when a single provider conducts planning activities and provides that direct service or support to the person, there may be an incentive for the provider to include themselves in the plan. So this is sort of just outlining what the potential conflict is there at that eligibility needs assessment piece and with the planning piece as well. Go ahead and proceed to the next slide. This slide just points out the policy that outlines that conflict. You can see this is referencing the 1915I language and then 1915 C language as well. So sort of just outlining where in policy this comes from. Go ahead and proceed to the next slide. So we just went through what is conflict. So we want to talk through what is conflict-free. Go ahead and proceed. So conflict-free is when there is some kind of separation or firewall between providers that are conducting eligibility, needs assessment, and planning from those that are providing direct services and supports. So you can see here, there's provider organization A, who's conducting that eligibility needs assessment and planning, and then provider organization B, that's providing that direct service or support. And you can see that yellow firewall sort of separating these two organizations here. You can go ahead and proceed here, and we'll just show you a visual of that firewall and where that language comes from CMS. So we also just want to note here, as you're seeing, so it's yellow firewall. We just want to acknowledge too that although this is referencing a firewall or a separation, what's not necessarily displayed here that is still really important is those relationships that provider organizations have with each other that just make the service experience or the support experience much smoother. So that communication about changing needs, coordinating services and supports, communicating records, any communication that really makes that experience smooth and seamless. So that there is that firewall piece there, but also we're assuming as well that there's also those other activities happening between provider organization A and provider organization B. So in summary, the firewall doesn't mean that the two providers don't engage at all. It just means that they shouldn't be financially related to each other, or they should be financially separated. And that yellow wall image there with the policy language is just referencing CMS's language there. You can go ahead and proceed to the next slide. So that was talking about a firewall. We've also previously talked about a safeguard. And so safeguards are procedures that can be added to a system to help mitigate against risk. So safeguards we sort of think of like, if there's not a firewall in place, a safeguard is like taking the roof off of the provider organization and sort of looking down into it and seeing and making sure that there are protections in place. So that's sort of what the safeguard looks like, is sort of looking at individual organizations and making sure there are mitigation strategies in place. So you can go ahead and proceed to the next slide. And then go ahead and click again to show the words there. Thank you so much for transitioning that. So a safeguard, like I mentioned, a safeguard is a process that attempts to mitigate against risk. So this includes things like, or it could include things like independent facilitation and self-direction. And these processes, as mentioned in that first bullet, are certainly best practices for a lot of different reasons, putting the people at the center of decision-making. There's tons of benefits to those processes, but by themselves, the processes are not compliant with the strictest interpretation of CMS requirements, meaning they should continue to be in place, but they add a lot of value, but they can't be the only way to mitigate against conflict or to prevent conflict, according to CMS's, the strict interpretation from CMS. Go ahead and proceed to the next slide. So now we're going to jump into the work group process. A work group was formed in January of 2022 by gathering membership from a variety of different work groups and venues. The goal of the work group was to bring a diverse set of perspectives to talk about conflict-free access and planning. They've been meeting monthly since January. So you can go ahead and proceed to the next slide there. This shows the work group journey, or where the work group is heading. The work group is going through an inform frame feedback approach, which you can see with those green arrows, inform frame feedback loop there. So the goal at the end of the work group is to provide the state with a feedback package, as we've been calling it, that outlines each potential option for conflict-free access and planning, and then each of its pros and cons, right? Because certainly any option will have pros and cons to it. And then it also will outline the group's priorities, and then that will be provided to the state to help support its decision. So that's sort of a summary of where the group is heading and where the group is moving towards there, and sort of that summary of what the outcome of the group will be. But I do want to pause here and just, Belinda, if you have anything else to add here, or if we have any questions, we can go ahead and answer them now.
Hi, nothing to add from me, but just did want to check in. I'm sorry, there's a question.
Yep, I apologize for my technical difficulty where I couldn't read the questions.
That's okay.
You initially asked, Belinda. So I do have two questions that came in for Belinda.
Okay.
Well, we had a couple questions asking about if you can expand on what were specifically the changes for payment for providers and changes to the HAB waiver qualifications.
So we're talking about the flexibilities that I covered under the public health authorities. It was allowed, I think what you might have heard about were stability payments, where the PIHPs were able to assess their provider network and assure that they had adequate providers to support during the public health emergency through stability payments. So that would have been sort of one of those flexibilities under that. What was the second question again?
Changes for the HAB waiver qualification requirements.
That might be related to the provider qualifications, I'm thinking, and there was just a reduction in the requirements for what trainings or qualifications the provider had to have before providing those services. Some were maintained, but others were stripped away so that we could expedite making sure that there were adequate supports and services for people during the public health emergency.
Thank you. And one more question for Belinda's portion. What is the approval process for moving flexibilities to permanent?
So the approval process would be that the department would open up the benefit plan. So the 1915C waiver benefit or the 1915I or the 1115 and or maybe multiple applications might be needing to be opened up because they operate together in providing the benefit to folks. So we would have to open that application, add the flexibility to the application, submit it for public comment for 30 days. And then once that public comment period is over, submit it to CMS for review and approval. And if you receive approval, then it becomes a part of the benefit for the period that is approved for that application.
Thank you, Belinda.
Yep.
I think it answers a follow-up question about their asking for a link for public comment. We're not, if I understand, you're not to that point yet.
We are not for the application changes because we have not made those changes yet.
All right. There are a few more questions that came in for Remi. Can you give an example of a setting that is not currently home and community based? Is this mainly nursing facilities?
So I think that might be for me, Remi. And the setting that is not considered home and community based is any setting that by definition from CMS, Centers for Medicare and Medicaid Services, is institutional in nature. So it would be what you would think of as a nursing home, a hospital, and or a psychiatric hospitalization.
Thank you. Follow-up question to that. am I correct in understanding that the individual themselves would be ineligible for HCBS funds, or is it the setting?
It's the setting.
Thank you for that clarification. The next question, what is the monitoring process to ensure that safeguards are being implemented?
Belinda, I can go ahead and jump in, and then if you want to chime in as well. Because there hasn't been a final decision made on conflict-free access and planning, that hasn't been fully defined yet. But as, and in this slide as well, you can see sort of that timeline of where that's heading. That will certainly have to be part of the process to say, you know, how to monitor compliance with the option that the state decides to proceed with.
Okay. Question about the work group. Is this a state work group, CMH work group, Medicaid work group?
Yeah, so this is, and Belinda, feel free to chime in too. This was a work group that came out of the Quality Improvement Council. And then there were a number of other work groups that were, membership was elicited from as well. So it started through the QIC.
Right, so it is representative of the provider network, CMHs, PIHPs, families, advocate organizations, the department, and we are looking to, again, invite stakeholders that are impacted directly by the receiving services. So we want to make sure that we have their voice in this discussion, and we are talking about a way to specifically target the person served in this conversation.
Question for Remi, is conflict-free one option and then the placement of safeguards another option?
I love that question. Thanks for asking that. There are several different ways that states have implemented it. Certainly those safeguard pieces do play a really important role, and they can be implemented alongside any option. And they you know, certainly offer great benefits outside of mitigating risk, right? They're best practices in their own right. And so certainly moving forward, that will be something to take a look at too, is which options, and then is there a way to, you know, use different approaches together in unison with each other. But there's definitely different ways that states have implemented that.
Thank you so much. That's the end of our questions at this time.
Okay, I'm just checking to make sure that Al Jansen is now on the call with us. Al, are you there?
Yes, I am.
Hi, Al. Welcome. And we're going to go ahead and hand it off to you for you to talk about the direct care workforce shortage updates. And Al, I don't know how long you've been on the call, but what we're doing is just having the slides moved by the facilitators here. So when you're ready to move over, just let them know. And then we're going to take questions at the end.
All right, very good.
Thanks, Al.
Well, good morning, everyone. I appreciate the opportunity to talk about this subject. Let's go to the next slide, please advance. So I think one of the things to start off with is that the workforce shortage is considered by most of us at the department as the #1 critical issue, and that includes the person I report to, who is now Director Hertel, and as well as there's quite a bit of conversation at the governor's office, certainly within the legislature as well. So it's a complex subject because there are so many aspects to addressing the shortage. But I wanted first of all to assure you that it is top of mind nearly everywhere. In my new role, it is one of the topic areas that Director Hertel has asked me to coordinate. Second is that the current effort with the direct care task force is really important. That is a very broad-based task force. Some of you on this call might be participants in that. It really is to create some sense of what the priorities are for the department and to recommend those things. So one of the things that has been a priority has been creating a professionalization of the direct care workforce. And one of the ways to do that is to create competency standards. So that task force made a recommendation to Director Hertel about 6 weeks ago, maybe 8 weeks ago, on competency standards. And those were approved by Director Hertel and moved back to the task force, and I think are now being communicated across the field. The third thing is the governor's proposed budget, and that clearly has some items in it that are related to the workforce shortage, including wage issues, including expansion of some residential kind of models. And incidentally, in those expansions of those residential models, one of the things it's built on is an enhanced wage for the providers who, assuming that this does move forward at some point, it does have an enhanced wage built into that. The third is a behavioral health supplement, or the fourth is a behavioral health supplemental. And it's very common that there are supplementals for each department every year, and this one has been stalled due to politics. However, buried in the supplemental, and I am happy to report that a week from yesterday, so next week, Thursday, there is going to be a meeting with some lead legislators about seeing if there is a way to move the supplemental forward. But in that supplemental is also some additional dollars for direct care workforce. It is one time, but there is additional dollars, and as well as some other items. But that's the one to primarily highlight for this group today. There are advocacy group proposals coming in almost as fast as I can read them. Some of the, and I'm not the only one getting them, to be clear. Several around training ideas, and they're really quite interesting. But we are encouraging any advocacy group with ideas on how to improve the workforce shortage to certainly move those forward to us. And lastly, we're trying to dovetail strategy with national efforts, not because we need to, but some of the strategies really do connect back to policies issues or even paperwork issues that are requirements through CMS or SAMHSA. And so dovetailing with the national effort on workforce shortage is just a prudent thing to do, not conditional. We don't have to do that, but we are doing that where we can. So you'll see a little bit more of that through the rest of this presentation. Next slide, please. So this is data that is national. Just many of you probably really are aware of a lot of this data, but across the United States, there are 4.5, and actually a recent study by the same national group has now turned it into 4.6. But nonetheless, a lot of individuals that are in the particular group broadly defined as direct care. 40 to 60% turnover. And of course, we know that there are some that are lower than that, or at 25, but there's also some areas where the turnover rate is actually 95%. 84% of the folks who are providing care do not have retirement benefits as part of their package. In 2019, 53% of the folks providing this care were women of color, and it was approximately 85% that are women and 15% men that are providing the care overall. I think a very disappointing factor here, and this is also true in Michigan, 47% of the folks providing this care do qualify for public benefits. The median income, again, nationally, $20,200, although that's not too far off. We're a little bit above that now after the pandemic boosted some of the wages, but that certainly was true in 2020 in Michigan as well. And then the national shortage that is predicted by 2030 is 151,000. And I believe the shortage that we are seeing in Michigan right now is about 36,000 folks that we feel like we are short. And I also should have mentioned that the number of workers in Michigan, by the best number we have, which honestly, everyone, this continues to be a moving target as we dig deeper into this, but the number we've been using recently is 165,000 direct care workers, and I'll give a little bit of definition in a moment of who those are, but 165,000, and then I was at a presentation recently where that number had moved up a little bit, but that's in the ballpark for the state of Michigan. Next slide, please. So I wanted to mention, I didn't say this before, there is some boilerplate that is moving through the legislature, which is really to, the wage pass-through was a very, very good thing, very needed, but it was complicated because it was done quickly and it didn't have all of the things in it we'd like it doesn't always pay for the other costs for an employer. It doesn't deal with overtime very effectively, and it also it really it puts a burden on some other employer issues. So there's a current boilerplate which is in work right now with Representative Whiteford to hopefully fix some of those. I guess I'd call them loopholes, or at least issues that have not been resolved. So the definition there is to provide essential services through CMHs and long-term care systems to support individuals with intellectual, developmental disabilities, mental illness, and older adults in a range of settings, including their homes. When we move to the national level, it's DCWs to assist older adults and people with disabilities with daily tasks like dressing, bathing, and eating, errands, appointments, social interactions, engagements, blood pressures, range of motion exercises, finding and keeping jobs. And then the titles are pretty varied, and I'm sure that this will expand, but it includes personal care aides, home health aides, nursing assistants, hospice aides, community living service providers, job coaches, home care companions, and of course this is provided in group homes, residential care facilities, assisted living facilities, continuing care, retirement communities, and nursing homes and hospitals. So the role is really very, very broad. And of course, in my early part of my career, I was a psychiatric aide. It was the title I was, but it really fed into the same category. It was in a hospital with adolescents. And of course, what you really know when you do these jobs, it's other duties as assigned, depending on what the therapist or the treatment team wants you to do. So this is a robust group of people who provide very core essential services. And I think that's really driving a lot of everyone's efforts to make sure that we take this moment to really address this and try and resolve the funding, but also a lot of the other issues. Next slide, please. So again, the current efforts of the governor's 23 budget, which does have, again, dollars in it for the stabilizing the wages, although it's really just formalizing the 235, not any additional dollars. Loan forgiveness, and then the behavioral health supplemental, as I said earlier, also has a residential component in it, and as well some one-time ARPA-related funding for direct care staff broadly defined. The current effort on the professionalization is around the competency standards. And again, we did not state from the department that they are mandatory, but that we as a department support them and are encouraging others to adapt those. And I think what we really like about the professionalizations, or those competency standards, is that it also then dovetails. It is intended to create training programs that are congruent with those competency standards. So hopefully that will be able to move forward. We're also working on an administrative rule change, and that expands the loan forgiveness. It's a little bit complicated and kind of deep in the weeds, but there is a method to do loan forgiveness that our community mental health have been able to use previously. But because the state of Michigan does not have an alignment on the definition of certain factors that the federal department does, we actually have lost some ability to provide loan forgiveness to, I believe we've lost about 40 individuals to other departments because the loan forgiveness was removed from the CMH. So anyway, this administrative rule change is to fix this. And then I already mentioned the boilerplate to clarify the direct care. So I think there's pretty strong support for that. That was actually asked for from one of our legislators. So I think once we get it moving forward, we'll be able to do that. And then what that will allow is that anytime there's any other future wage pass-throughs, it'll have the flexibility that it needs. So we're looking forward to that moving. I should also mention that under current efforts, this is fairly new, is that there are lots of strategies, lots of departments, lots of administrations working on direct care workers. I guess a strategy to address that. And even though everyone knows that 80% of the issue is finding a wage and really getting a wage that is at least survivable, and hopefully is stronger than that. There are lots of other strategies, and one of the things that we're working on, in fact, I was doing just before this meeting, is working on a strategy to bring all of the administrations together so that we begin speaking with one voice and sort of one effort to address not only the wages, but all of the other things that are, that, as you'll see in the next slide, that are part of this. So that is going to move forward with, I think, a senior team. That's the intention. That will start to coordinate strategy on addressing this. Next slide, please. So I'll restate again, this is a really complex issue and needs a broad strategy. And no matter where you look at this issue, you will find that it seems simple at first, and if you only focus on the wage and benefit issue, it is simple. But there's a lot of historical issues embedded in the direct care worker that really are, I think we have the opportunity to address. So under wages and benefits, I think one, we're looking at what does the minimum starting wage need to be. And while we haven't endorsed a very specific number, most of us in conversations are seeing that the wages need to be at approximately $17 to $18 an hour to start. And we also understand that there are some benefits that are missing. Not everyone gets health care. And also the retirement benefit issue needs to be addressed. And also when you address wages at the front of the beginning of the issue, you also have supervisory and other wages that need to be adjusted. So all of that is embodied in the wage and benefits, and it's at the top for a reason. We need to deal with that aggressively. So we are supporting any conversations that are after what that wage needs to be. And again, I've had several across the state, and in certain parts of the state, it's recommended that we start at $16 an hour, and others it's 18, and there's one region where it's actually 21. So anyway, that'll be a complicated conversation when we get to actually creating a definite ask with the legislature. The professionalization, I think, if we can work on and get the competency standards connected to a national model for training, and that training has some reciprocity across a broad set of providers. A broad set of areas, administrations, then we will have come a long way in professionalization. There's like a whole lot of other things under professionalizations, having billing codes for direct care workers, having direct care workers be on committees. So I'm not, due to some time constraints, I'm not going to go into that detail, but I will tell you that in the list of strategies that have been put together, trying to knit all of the administrations together, there are over, I would say, 70 legitimate, worth to consider strategies. So it's large and complex, and of course, only one of those is wages. So there's another 64 that are not about wages. Designing a career pathway, we need to, it's a bit of the professionalization, but a more specific area, which is this needs to be a pathway to a permanent either position that you really want to stay in, or in other places in social work or nursing, or other places that are career advancement from your point of view. So that's really what the intention is there. And there is some effort going on that with an internal department that's responsible for workforce development. So again, that's a conversation for another time, but just understand there is some work being done there. I think we need to really elevate the value. It's recognizing the dimension of what people do in this broad-based role, to recognize that it's essential, and then elevate its applicability as part of a treatment team and its importance in creating community level work. And then lastly, we need to collect data to really demonstrate the impact of any decisions that we make or that we implement. So I think that can be on any one of these areas, but we need to be able to demonstrate to the legislature, to the taxpayers, to the direct care staff, and to the agencies that whatever we collect information on is having an impact, or if it's not, that we need to alter our strategies. I do not take credit for these 5. These are an accumulation of items from national as well as lots of internal conversations. So what you're seeing here is a strategy that we are going to put forward, but it's coming from a variety of sources. So I packed a lot in my 10 to 15 minutes here, but I'm happy to take any questions and elaborate on anything if there are any questions. But thank you for attention to this.
Hi, Alan. Thank you. I do have some follow-up questions.
All right.
In the boilerplate language, does that address who is considered a direct care worker? For example, does it exclude nurses and other high wage earners?
Yes, it does. It really is focused on the largely the group of folks who got the 50. Remember the original 50-cent pass-through for some of you on this call, and the most recent $2.35. It would be an extension of that particular group. And I'm happy to forward the boilerplate so that people can get an exact reading of what's in there, as well as there'll be if you have any issues with it or would like to have an expansion of that. I am not the originator of it, but I can certainly include that in it. So you can communicate any concerns back to the folks who are pushing this boilerplate through.
Thank you. Next question. You mentioned that the department didn't formally adopt the competency standards, and so they're not mandatory. Can you talk about that a little bit more?
Yeah, that was really just a matter of timing, I would say, is that we, Director Hertel wanted to quickly provide support to the advisory committee and move it out as something that we were supportive of and encourage folks to adopt that. But that's fairly common first step for us. I would say that in the future, if needed, we will revisit the issue of whether it needs to be mandatory. And I recognize that having been a provider, that sometimes you wish that we would just do that. It is a little complicated with a variety of folks who are in that role. So that was the other reason, but it's not, we're not unwilling to do that in the future.
Follow-up question about professionalization of the direct care workforce. There's an initiative at the federal level to establish a standard occupational classification for direct care workers. Is that a discussion in your department? Is that something that is supported in Michigan?
That is a great question. Yes. And again, that list of 65 strategies, or actually it's more than that right now, but in that strategy group is in fact that very issue. So I can't say that we have actively supported it or not at this juncture, but that senior group will be addressing that as I would say within the next 30 days, we'll start looking at prioritizing all of those strategies. Initial broad conversations without a lot of due diligence on the question, is there is support for that? Yes. But I wouldn't want that to be taken as absolute department support yet, but initial discussions, yes.
Thank you. We have a next set of questions, and I'm not sure if they'd be best for you to respond to, or of course, any of the other presenters can chime in. Lots of questions about home environments. And the first question specifically, they would like an elaboration and explain a little bit more about expansion of residential models.
Oh, sure. I think, Belinda, that sounds like a two-part question, and I can certainly address the second part. Is there something you want to respond to in the first part?
Yeah, I need that question repeated again, because it does have a couple of pieces to it.
Let's start with, can you explain more or elaborate on the expansion of residential models? Probably start with the definition first.
Okay, so that sounds like we're asking a question about the boilerplate or the supplemental, and as well as the governor's budget. So here's what we did, and I'm going to sound vague because there's a little bit of vagueness to answering your question. So at the 11th hour, we were asked to what we needed to address the emergency department boarding and the folks who are in state institutions who've not been able to get out. So at the 11th hour, we said we think we need 48 beds for adults to address those two issues, and 12 for children. So here's the only thing we did say, is that we wanted to be residential based, so not inpatient based, not step downs to inpatient, but residential models. Probably they would be aligned with the psychiatric residential treatment facility model. That would be one of the things that we would be looking at. but I would say that they are settings that would be intensive residential that could support individuals either as step downs out of the state institution, or for whatever reason, they're not quite qualified to be placed in the inpatient and they are in an emergency department. So we left it vague on purpose, not because I actually would kind of love, and Belinda is probably sitting on her hands as well, going like, I'd love to answer that in more detail. We purposefully didn't do that because we wanted it to be a conversation with the community if it got supported by the legislature. So it is very broadly stated. So I'm gonna leave it at that. And I don't know, Belinda, if you want to put any finer point on this, but we were careful on purpose because we wanted it to come out of the needs at the time when it got supported by the legislature.
Right, thank you. That allows me to reread some of these questions
Okay.
in light of that information. So the next set of questions, I guess, aren't related to that the current proposal, but they circle back to HCBS directions on home and community-based settings. Where can we find out about limits that are set for group homes, as in the number of residents or other items? Where can we learn more about that?
So there's a link to a page that will provide you resources and frequently asked questions. At this point, CMS nor has the state of Michigan set any limits related to size of settings. Instead, the focus is on what is the makeup of that setting, in that it is community oriented and that it allows each person in that setting to get full access to their community as they choose.
Thank you. Earlier in the presentation, it was mentioned that some settings are not in compliance. What would that mean for the individuals? Where would they move in this current housing crisis climate?
So at this point, no setting has been determined to be not home and community based. It is a preliminary status that a setting might be in what they're calling heightened scrutiny, which are those settings that are either institutional in nature or isolating the individual from their broader community. If that setting, through the evidence collected, through the heightened scrutiny review process by both the department and CMS, is not able to be approved, then there would be work with the department and the PIHP to assure that through a person-centered planning process, that person has choice in receiving services with a setting or provider who is determined home and community based. So it is for all of us the hope that every provider that has been involved in this process will be able to get to a place of compliance and be approved by CMS to continue to provide services. However, if that is not the case, there will be lead time of at least 6 months or more for those individuals impacted to have a discussion with and be a part of a person-centered planning process that helps them to understand their choices and where their services or setting might be able to be for home and community-based services. What we do know in the data we have so far is that the majority of the settings that are under heightened scrutiny are a mix of both group homes and community services such as supported employment, out-of-home non-vocational, pre-vocational, and skill building. So it is not the case that every provider or setting that is on heightened scrutiny is a setting where someone lives. It could be, though, where they might be receiving service.
Thank you for that explanation. Follow-up question. When is public comment going to start for regions 1 through 4 and 6 through 10? How long do you expect CMS to make their decision on the list of settings? It just seems like time is running short to give someone that 6-month transition period.
Right. So the second phase of the public comment for the remainder of the state, those regions that have providers or settings 1 through 4 and 6 through 10, will be starting this month. And again, it's a 30-day period, so we look into mid-July before we would complete that process and then be able to review both the Region 5 and the remainder of the state, so all 10 PIHPs by late July. We are in conversations with CMS because CMS has indicated that there is a way forward for states who need to extend the time frame for their the end of that compliance time frame of March of 2023. You do have to have a lot of evidence to speak to why you need that extension, and it's unlikely that it will be granted easily. So we again think we have a timeline that is tight but not unmanageable to be able to then make some decisions by late August, early September, and make sure we're notifying people in advance of that March timeframe. Note that the providers who are on heightened scrutiny know that they're on heightened scrutiny. So it isn't, there isn't anything stopping the provider and those who are living in those settings to start having those conversations now, to just be sure that they're starting the conversations early in case there is a need for transition to occur.
Perfect intro to the next, or segue into the next question, Belinda. How can someone know who is under heightened scrutiny? Is that something available to the public?
So it will be, if it hasn't already been, through the public comment period. But if there is a need for you particularly to know where your provider stands, again, the provider has been informed and the PIHP HCBS leads have that information and would be able to provide that to anyone who asks.
Thank you. The last question that I'm seeing at this time, how are self-directed families included in these work groups?
I am thinking you're talking about the conflict-free access and planning work group, perhaps?
That's my assumption.
And again, we want to make an effort to circle back to assure that we have the voice of all those who are receiving services, no matter the type of service or the arrangement. So if there is an interest in being a part of the group or sharing your perspective related to the conflict-free access and planning work, feel free to reach out to me at HAWKS, B as in boy, at michigan.gov. And I'll be sure to include you in future conversations that we have related to talking to those served in this work group.
All right, thank you. I think that gets us through all of our questions that have come in. And I'd like to direct everybody to, if you didn't grab a copy of the handout slides in your GoToWebinar control panel, look for the tab that says handouts and you can download the presentation there. And there have been some links shared in the chat where you'll be able to find a recording of today's presentation. So thank you so much to our presenters. And
I want to thank everyone for attending. We really appreciate it, and thank you to our presenters for giving us really valuable information. I want to ask everyone to consider attending next week when you'll hear from our lobbyist, Kristen Noner, who is from McCall Hamilton Advocacy and Public Affairs. She usually talks about elections and how you can get involved, and then some public policy stuff that the ARC is working on. So it's usually a really informative session. Again, thanks to everybody and have a good weekend.
Thank you so much.
Bye-bye.
All right, thank you.